Thank you very much for the nice introduction.
Spell it first, please.
A2 diet. So you said it right. We'll talk at lunch. Anyway, it's always difficult when you have two mics. What I will do in the next 20 minutes, I know it's only me in between you and lunch, but I will take you through a recently published data from the real world practice. Those are my disclosures. And sorry, I need to go back. What I will do, I'll just take you through a brief introduction to put you back in context, because I'll take you back from technology to the real world and more facts about diabetes and what we are doing. Then I will go through the study organization, also the baseline characteristic, and I'll go through the results and what the outcome of this study, tolerance to the medication being added, and I will end up with a few conclusions. So I know everybody, when you see the slide, you'll say, well, we know this. Yes, we do. And we know that's almost like that's the IDF this year, 2025, and it's like more, almost 600 with diabetes, and in 2050, there will be even up to 900 million of people with diabetes. And the global prevalence for now is 10.9. So there's cost, and the cost is very, very important, either cost in money and cost in lives. And those who they lose their life per year, 3.4, those attributed to diabetes. What's really frustrating is this, is there is no improvement. So when you look at the patients who they are uncontrolled, they are 45% to 93%. I don't want to undermine what's been said in the technology, and technology make the control good, and I'm not against technology. However, how many, when it comes to the percentage, they have that in control. The second thing is that the delay initiation of the second line treatment, it takes a good number of years, 5.6. Not only that, if you look at the average A1C, when the healthcare professional decide to add another medication, is more than 8. So all these are really important when it comes to the real world data and our daily practice. So the other important thing is when we add or with multiple pills, what's the adherence is 46%. So there is urgent call for effectiveness and adding the medication, that's the intensification, and not only that, it's the organ protection as well. The guidelines, whatever they are, goals are clear. So the goals are to cardiorenal risk patient, the cardiorenal risk need to be reduced and looked after, and not only that, achieving the glycemic goal, and again the weight loss or at least weight maintenance. With that in mind, what I'm going to introduce you to, so those we need effective treatment, highly effective in form of reducing the weight, the A1C and weight, and also the one you have organ protection or cardiorenal protection, which is the sulfonylurea, and adding to them the SGLT2 inhibitors. So if we look at the guidelines, most of them support the notion what I have told you in a minute. This is the IDF, and the IDF, they talk about the early intensive for glycemic control, and also the initial combination therapy. The harmonization between the glycemic control and organ protection, and those are the two goals I already told you about. So when it comes to sulfonylurea as important option, with the combination of SGLT2 to serve those two goals. The other thing is that the NICE guidelines, again, support the SGLT2 as a first-line treatment for those who they are intolerant to metformin, and also support the combination therapy with SGLT2, as SGLT2 being tried with lots of other background therapy. the multidisciplinary practice recommendation for the management of diabetes, cardiorenal and metabolic diabetes, also support the holistic approach to treat all the risk factors. So if we took the sulfonylurea in form of glycoside MR, which they stimulate insulin secretion, and with that decrease the blood glucose level, and go to the the SGLT2, where they eliminate the glucose by blocking the reabsorption at the kidney tubules, plus the cardiorenal protection, I think we'll be able with this synergistic effect to sustain the glycemic control and provide the patient with cardiorenal protections. So just to give you some data where the other glucose-lowering agent being added to the sulfonylurea. And what you see when it comes to the A1C reduction, you can see there is a reduction in A1C. And if you look particularly on SGLT2 being added to sulfonylurea, you see there is very efficacious, and this is A1C on the right side of the unity line. Also, when it comes to the weight loss, that's an issue. So people, they might think that the weight will be increased if they background, and this is the recent or the third generation sulfonylurea. In fact, there is weight loss numerically. This is when it comes to the hypoglycemia risk, which is another risk we look for, is when you add SGLT2 to sulfonylurea, there is probably very mild risk of hypoglycemia, but it's not significant at all. So coming back to ACT2 DIA study, which is a real-world data, and we know these days the real-world data became very strong when it comes to the level of evidence, because that takes us to the real-day practice, what we see in the clinic. We know the randomized controlled trial are very important to answer the question of efficacy and safety, but it doesn't look exactly as the real-world practice where every patient free to come through to the clinic. So let us look at the study design. The study design, the study has been done in like 25 sites and included 537 patients out of 575 patients, because 38 they were not eligible. The design of the study is follow-up study to the daily practice and the baseline characteristics and the data. Then there is a follow-up. So the baseline data being collected is the diagnosis, A1C, fasting plasma glucose, ongoing type 2 therapy, and comorbidity, blood pressure, lipid profile, cardiovascular and lipid-lowering medication, and weight. And the follow-up period is during the follow-up, they looked at the A1C, fasting plasma glucose, and the if there is any therapy being modified, blood pressure, lipid profile, weight, and event of interest. And the country this study be run in, Brazil, China, Philippines, Turkey, and also Saudi Arabia from the region. Those who they been included in the study as the type 2 for at least 2 years prior starting the SGLT2. Again, those who are treated with the glycoside MR at minimum dose of 60 milligram per day, and the minimum 60 days of starting the SGLT2 combination with the glycoside, the presence of at least 2 A1C 60 days after and at the baseline after adding the SGLT2 to the treatment. What is the background therapy which has been included? Metformin, DDP4 inhibitor, insulin at low doses around 20 and below. What's the primary objective of the study? Is the A1C difference throughout the follow-up. 6 months, the end of the study is 2.4 years, and they looked at the 6 months as well. And of course, they looked at other secondary objectives with the proportion of patients reaching A1C target less than 7, also assessment of the treatment pattern of the SGLT2 and glycoside MR, change in the lipid profile, blood pressure, weight, and any onset of a new comorbidities and adverse events of special interest. So the baseline characteristics is when it comes to the ages 59.5, almost 30.5 is 65 and above, and 69.5 is below 65. And the average male to female almost equal. The duration of diabetes is 10 years. Looking at the BMI distribution, it's mainly above 25, almost 75.5. They have higher BMI than 25. Here, looking at the additional cardiovascular risk factor at the beginning of the study, 59.8 they have hyperlipidemia, 63.5 they have hypertension, and 15.1 they have established cardiovascular disease. They have nephropathy and neuropathy, but surprisingly enough, it's quite low. It's only 6.9 when it comes to the nephropathy and 12.3 when it comes to the polyneuropathy. Quite important at the baseline, those who they were wouldn't target A1C is below 7, it's less than 15%, and the study exactly is 12.2, and you can see the distribution there. But 63% of patients had HbA1c of 8 and above. It's just exactly similar to the data published by the IDF I showed you in the first slide. So, looking at the average dose of the glycoside, it's 76.6, and also 3.1 year, that's the duration between initiation of the SGLT2 and the high A1C. The background therapy is 77.7 on metformin, and 49.4 on DDP4 inhibitors, and glycoside MR on SO is 14.2, and low doses of insulin is 6.7. And the other interesting thing is, and the finding is, the number of medication they were on. So if you look at the three, there are quite few of those patients on the 3 medication together, okay? And if you look at the, so it takes time to do the intensifications. The average is 1.3 medications. They now looking at why the SGLT2 being added. What's the mere reason for the healthcare professional to add the SGLT2? And the mere reason is the glycemic control, okay, and the cardiovascular risk. Then the other reasons are renal benefit, weight, lower risk of hypoglycemia. But those are the 2 mere reasons of adding the SGLT2 to the medication as intensification. And what are the most commonly used 2 equally is the dapagliflozin and the empagliflozin. These are the baseline characteristics for the lipid, not terribly within control. However, 61% of the patients who at the baseline, they were on cardiovascular protection medication, mainly for hypertension. And the anti-lipid medication, 67.8, and the medication class, it's mainly statin. So the follow-up period, and let us look at the A1C, and those results are after 6 months, okay, after adding the SGLT2. So if you take everybody together, it's 1% A1C reduction. If you take the A1C 7.5, it's 1.2. And of course, we know from all the previous study, the higher A1C, the higher the reduction. So the A1C is 9 or above, the reduction reached to 2.5% in A1C. This is the 2.4 years at the end of the study, and this the primary endpoint is the all patients 0.7. Then those who they are above 7.5 or above is 1. Then the A1C above 9 is 1.9. So you can see even till the end of the study, there is a durability. So here, what we are looking at is looking at the 3 years, those patients being followed up. And again, you can see there is maintenance when it comes to the A1C reduction. So the proportion of patients who they reach the target, which is below 7, before there was 12.8, now it's 29.3 at the end of the 29.3 at the end of the study. Other outcome quickly. This is the weight, 1.7 reduction in weight. This is the lipid profile. So you see numerically they are higher in the good side. So the TG and total cholesterol and LDL. HDL no change, but at least there is no reduction. Blood pressure, again, there is reduction in systolic and diastolic blood pressure. Here is the patient who they've been intensified. So we know the one who they were on cardiovascular protection and also the lipid medication. So the intensification only 13.4% throughout the study. And those who they were on medication before, they've been intensified by 18.1 by adding another anti-lipid medication. Type 2 therapies during the follow-up, so 2.4, the mean duration. That's the mean duration for people to put the two together. And also, if you look how long those patients stay on the combination, so 2 to 12 months is 11.5. There is increase between 12 to 24 months to 26. And what's more important is between 24 to 36 or over 36 months, it's almost 60% of the patient on the combination, and that tells us the tolerance to the combination and to the medication. Those are the treatment discontinuation. Nothing significant, very few, 7.6 for the SGLT2 and glycoside is 6.2, but two together is only 2.2. That tells us exactly the same thing, but the dose modification. So the dose modification is, again, it's not that, it's 14.5%, and for SGLT is 4.8, which is when it comes to the intensification, we're still not doing well. Looking at the intensification, 19.2 of patients had treatment intensification other than those in baseline, okay? Only 19. And how long it takes, it's 1.4 years. The other important thing is 18.6 of all these patients received one additional glucose-lowering agent. So the mean choice mainly for the intensification throughout the follow-up was the DDP4 inhibitors and the insulin, 37.9, and the insulin 35%. And if you look at the patient, how many tablets they are on, not necessarily anti-diabetic or glucose-lowering agent, other medication, is 48% is for medication. So I think, as we have learned previously, single pill combination will help quite a lot when it comes to the compliance. So tolerance, nothing new, not significant at all. Those are the hospitalization. Only 12 with CVA event, 1 bone fracture, 1 ketoacidosis, 1 hyperglycemia, 2 UTI. And when it comes to the unscheduled visits, so those who they come earlier without them having the routine follow-up visit, it's only 1.3. So the events, cardiovascular 5%, only dyslipidemia 4.1, neuropathy 2.4, and psychiatric events is 0.9. So again, when it comes to the renal events, is for patient only 0.7. So it's quite, it's only 6 patients. It's either deterioration of the GFR or doubling of the serum creatinine. So with that, I hope I showed you something from our daily practice for treatment which will be, to a certain extent, cost effective, and it will be able to cover most of our patients. As we all know, still the patients who they have diabetes, out of the 600 million, 2/3 of them lie in low-income countries. So in conclusion, the combination therapy was administered to patients at high cardiovascular risk who were overweight or obese. Disease duration and control at the initiation of the combination therapy Most patients had a long disease duration, with 90% being uncontrolled. Clinical inertia, I think it was very clear from presenting the data. We took us some time before intensify the medication. And the situation observed in the real-world clinical practice contrasts with the recently updated guidelines recommendation, which support combination therapy at treatment initiation and early treatment intensification, and highlighting the need for effective management. Strong effectiveness if you combine the medication, and if you start that early, the long-term persistence for those patients who they adhere to the combination therapy, especially if they have a single pill combination. Cardiometabolic benefit, the combination therapy synergistically improve control of cardiometabolic risk factor and contributing to the overall better health. Good tolerance, as you have seen, and also weight, probably not massive weight loss, but at least there is 2 to 4 kg weight loss and the combination, and with less hypoglycemia. So it is safe. And those are the figures which will hopefully encourage us to add the combination or add the SGLT2 to the sulfonylurea safely when it comes to efficacious, when it comes to the A1C, safely when it comes to the weight and hypoglycemia. With that, the summary, it's very important now. I think we had this data published recently as at 2DIA, that should be encouragement for us to take the clinical inertia away, and hopefully it gives us real-world data to be able to trust adding those two medications together. With that, I'll stop here and thank you very much.
Thank you.